No man can fully grasp how far and how fast we have come. Man in his quest for knowledge and progress is determined and cannot be deterred. Those who came before us made certain that this country rode the first waves of the Industrial Revolution, the first waves of modern invention. And this generation does not intend to founder in the backwash of the coming age of space. We mean to lead it. We choose to go to the moon and do the other things, not because they are easy, but because they are hard. Because that challenge is one that we're willing to accept, one we are unwilling to postpone, and one we intend to win. But if I were to say, my fellow citizens, that we shall do all this and do it right, and do it first, then we must be bold.
Thank you so much for joining me this afternoon for what is webinar number 3 on the use of Barrigel as a rectal spacer for prostate cancer. Michael Chao is my name, and I'm from the Olivia Newton-John Cancer Centre, as well as GenesisCare Australia in Melbourne. I hope in the next 20 minutes, I will convince you that Barrigel is the best way of delivering safe, easy peasy, controlled rectal spacing for your patients. Firstly, I want to take the opportunity to recap on the important results of the Barrigel pivotal trial recently published in JAMA Oncology and brilliantly presented by our colleague, Dr. Martin King, in webinar number 1. So in summary, this is a randomized study comparing the use of Barrigel versus control in a group of patients with early to intermediate risk prostate cancer using contemporary moderately hyperfractionated radiation therapy to a dose of 60 gray in 20 fractions. The trial easily met its primary endpoint, with 98.5% of patients achieving a greater than 25% reduction in rectal volume receiving 90%, or the RD54 gray. We saw an average 85% reduction in rectal volume to 54 gray, with 20% achieving a 100% fall. As a consequence, we saw a significant reduction in acute grade 2 plus GI toxicity, dropping from almost 14% for the control arm to about 2.9% for the Barrigel cohort. No Barrigel adverse events were recorded, and this is the only randomized study that shows any reduction in acute grade 2 plus GI toxicity with the use of rectal spacers. Of course, given its short follow-up, it's too early to report on late GI toxicity, bowel quality of life, or even sexual function. That will no doubt come. And why may a reduction in acute GI toxicity matter? Well, the recently published PACE-B sub-analysis showed an association between significant acute and subsequent late GI toxicity. For example, in the SBRT arm, in the 12% who developed late G2 GI toxicity, 35% had prior acute grade 2 GI side effects. And those who had minimal or no GI toxicity reported much less preceding acute GI side effects. The relationship also stands for persistent late grade 2 GI toxicity. The unique properties of Barrigel, or NASHA, which stands for non-animal stabilized hyaluronic acid, allows for controlled spacing. There is no polymerization, therefore no time constraint on the injection process, allowing you to sculpt the implant according to your patient's individual prostate. Instead of the device controlling your insertion, with Barrigel, you are in complete control. Yes, I hear many people say the insertion may take slightly longer, but then again, achieving a symmetrical implant that allows you to attain all your dosimetric objectives. In fact, Barrigel hits that ball well out of the park, which we call a 6 in cricket in Australia, is priceless. When we compare Barrigel versus SpaceOAR, using the Fisher-Vaslak criteria, which is simply the presence of spacer at mid-gland, 1 centimetre above and 1 centimetre below at the midline, greater than 95% of patients using Barrigel achieved this mark, compared to 49% of Hydrogel patients. In fact, Hydrogel was absent at either the base or the apex in 68% of patients in their trial. We also assessed our first 102 Barrigel patients off trial, recording separation at the sagittal midline of the prostate at the midgland, 5 millimeters below the base and 5 millimeters above the apex, as shown in this diagram. In addition, we also assessed symmetry at the transverse plane of the prostate at the midgland from right to left, where symmetry was defined as greater than 50% of the recorded separation at the midline when measured at 1 centimetre to the left and 1 centimetre to the right. So for example, if the separation at the midline was 1 centimetre, then to be symmetrical, the measurements at 1 centimetre to the right and to the left of the midline had to be greater than 5 millimeters. So in our study, the rectoprostatic separation at the sagittal midline was a mean of 12 millimeters at a level 5 millimeters inferior to base, 11 millimeters at the midgland, and 9 millimeters at a level 5 millimeters above the apex. And apical separation is the critical component of rectal spacing. In addition, 98% of implants were defined as symmetrical at the transverse midline, with Barrigel measurements exceeding 50% of the separation measured at the midgland at 1 centimetre to the left and to the right. There is no doubt that this can only be made possible because of Barrigel's unique ability to allow you to sculpt the insertion with no time constraint. What about safety? NASHA, which is Barrigel, has an unprecedented safety history with more than 50 million procedures performed worldwide. In fact, it's been used in more than 400,000 children to treat the psychoureteric reflux. And so far, NASHA, as Barrigel, has been inserted in more than 10,000 patients worldwide. So we know it's safe. We have seen 0 Barrigel-related adverse events, 0 embolism, and it is still the only reversible rectal spacer on the market. So why is this important? The most pressing problem is, of course, rectal wall infiltration. The risk varies from 0.7% in the Barrigel pivotal trial all the way up to 6% for SpaceOAR. In fact, 2.7% of SpaceOAR patients had moderate to significant rectal wall infiltration. The odds of a truly significant rectal wall infiltration is, of course, quite rare, but this can unfortunately lead to rectal wall ischemia and then a potential disastrous chain of events with mucosal ulceration, infection, abscess, and then finally the dreaded fistula. The risk is rare, but enough for some to voraciously advocate against its use. And this is where Barrigel is at its best. Instead of throwing the baby out with the bathwater, we have instead found the safest product available for spacing. Now, this is a patient with moderate asymptomatic rectal wall infiltration, staring down the prospect of a significant delay in the commencement of his radiation therapy. However, with the use of hyaluronidase or hydrase, an enzyme that breaks down hyaluronic acid, it was completely dissolved within 48 hours, as you can see on this slide. A potential ulcer, abscess, or even fistula has been prevented. No need to dig this product out from the rectal wall. So Barrigel does make spacing even safer. Therefore, I'm going to encourage everyone to give Barrigel a go. It's easy to use with no assembly required. It doesn't set, allowing you to tailor your implant according to your patient's anatomy, delivering symmetrical implants day in and day out with minimal mentoring and a fairly short learning curve. And finally, it is reversible. And as I've said before, this is gold. However, I do understand the reluctance of some urologists and even radiation oncologists to change. Change is not easy. Some will say it takes longer to implant. Others will contend that SpaceOAR Vue will make it easier for radiation oncologists to contour. And some may even use SpaceOAR Vue as a surrogate for image-guided radiation therapy, or IGRT. Finally, some may even say Barrigel dissolves too slowly with an inherently longer Invivo half-life. Now, I did briefly mention the time factor earlier in my presentation. With any new device, it does take a little bit of getting used to, but the learning curve, I assure you, is fairly short. It now takes me literally less than 5 minutes to complete an insertion from the time the patient is all prepped and ready to go. It takes you that long to set up the hydrogel device with 17 steps and 8 separate parts required to prepare it for its use. Plus, as I've mentioned before, it allows you to perform controlled spacing, delivering symmetrical implants to your patients on a consistent basis to achieve the best OAR dosimetric endpoints. There's a saying, you can choose between doing things the easy way or the hard way. Well, I hope we all prefer to do it the right way. There is also no doubt that SpaceOAR Vue is easier to contour on a CT scan, as you can see on the slide. But our primary objective in prostate cancer radiotherapy is the accurate and the precise delineation of the primary target, and that is the prostate. Therefore, if at all possible, I request an MRI sim fused to the CT sim to obtain our prostate volumes. With an MRI sim, you can precisely contour the base as well as the apex of the prostate, including the urethra. In addition, you can also clearly see Barrigel as hyperintense on T2 weighted images. At the base, it can be very difficult to differentiate the prostate from the bladder wall if you rely solely on CT simulation. It becomes quite clear when an MRI sim is utilized. The prostate is easily defined and separated from the bladder wall. In addition, it also becomes much easier for you to define the urethra, both on transverse images and also on sagittal MR images. And this is becoming more important as we continue to dose escalate with either ultra hyperfractionation or targeting of the dominant intraprostatic lesion, or DIL, with extreme doses or both. At the apex, the prostate is almost impossible to accurately define without an MRI sim. On the CT scan, it is literally the same shade of gray. It becomes quite obvious on an MRI sim. And this is why we will always prefer an MR sim when delineating the prostate for high-dose radiation therapy. It's an important part of the workflow. And when you have an MRI sim, you don't need a radiopaque spacer. So when we actually compare CT sim prostate delineation in orange versus MRI sim in red, there is a tendency to overestimate the prostate base, which means including unnecessary bladder and the potential to either under or over volume the apex. Why is this important? Well, again, Kashan in the Mirage study has just shown us the dramatic impact a 2 millimeter reduction in PTV margins can have, with acute GU toxicity effectively halved. When you CT sim, you are always starting behind the 8 ball, with far more bladder included in your target. In addition, there is also the real risk of a geographical miss with undervoluming of the apex. However, if you are unable to obtain an MRI sim for whatever reason, be it for a contraindication or lack of access, Barrigel can still be seen on your CT images. Just vary the window levels and you can make the necessary adjustments to allow Barrigel to actually stand out more clearly from the prostate and from the rectum itself. I'm also going to touch on what some of my international colleagues have been doing. Some have used SpaceOAR Vue as a surrogate for prostate IGRT. I keep reminding them that this is not the primary target. It's the prostate that we are interested in, and this should be the focus. On a standard linac, I still recommend gold seed fiducials, not only for precise CT MRI fusion and stress-free interfractional tracking, but it is also essential for intrafractional tracking. And the latter is becoming an important part of the workflow, especially for moderate to ultra hyperfractionated radiation therapy. Unless, of course, you have an MR sim and an MR linac. In this scenario, you can certainly dispense with gold seed fiducials and rely solely on the wonders of new technology to precisely target and track your prostate cancer treatment. This is a cine image of a patient undergoing prostate stereotactic radiotherapy with the PTV boundary superimposed on his midline transfers image. And you can see Barrigel quite clearly on the MRI image. No need for any other views. Finally, if you've placed Barrigel in the perirectal space, does it actually matter if it stays in your body a little bit longer? It's essentially watered with natural hyaluronic acid, which is abundant throughout your body. In fact, I see a longer in vivo half-life as a distinct advantage, as it allows you to plan your Barrigel insertions well ahead of time. Instead of multiple lists to ensure rectal spacing is performed just prior to the commencement of radiotherapy, you can choose to consolidate all your Barrigel patients into a monthly list. So Barrigel adds to your convenience. So in conclusion, Barrigel is a second generation rectal spacer that is safe, it's easy to use, not to mention easy to learn, and it is also the most effective spacer as it allows for controlled insertion, delivering symmetrical implants. While a radiopaque spacer is fun to have, it is not necessary when an MRI sim is such an important part of the prostate cancer radiotherapy workflow. Thank you. Now, I've just got a couple of questions here from the chat box. Question number one is, can you share your experience with hyaluronidase or hydrase and reversing a rectal wall infiltration? What was the impact on the patient's treatment? Well, as far as I know, there have been 4 reversals out of the 10,000 implants performed so far around the world. I've been involved in a couple, or actually have been asked to be involved in a couple. Both were grade 2 asymptomatic rectal wall infiltrations. What we see is that Barrigel tends to ball up within the rectal wall instead of spreading throughout the layers of the rectal wall, as you see with hydrogel as it's injected as a liquid. And when you look at the data from the pivotal study for Barrigel and also for SpaceOAR, it was 0.6% for Barrigel, and the patient who actually developed the rectal wall infiltration only had minimal involvement of the rectal wall, whereas for SpaceOAR, the potential for developing rectal wall infiltration is about 6%, of which 0.7% is actually a significant rectal wall infiltration based on the Fisher-Vaslog criteria, which means that more than 25% of the circumference of the rectal wall was involved. But in these 2 patients that I was personally involved in, we actually decided to reverse the Barrigel within the rectal wall because we wanted to expedite their treatment and not delay it. And we were able to easily do it by injecting hyaluronidase into the Barrigel that was confined within the rectal wall. Hyaluronidase, as you know, is an enzyme that breaks down hyaluronic acid. We were able to identify the Barrigel within the rectal wall using transrectal ultrasound, and then insert a needle under sagittal guidance transperineally, just like as you would do for a prostate cancer biopsy, and infiltrate that Barrigel with 50 units of hyaluronidase per 0.1 cc of Barrigel that was contained. And we actually knew that the dose was high. We increased the dose. For dermatologists, they use about 20 to 30 units of hyaluronidase per 0.1 cc of NASHA that's injected cosmetically. But given that we didn't want to go back in, given that this was a day procedure, we wanted to do it just one time. And with 50 units per 0.1 cc, we were able to dissolve it quite rapidly. MRIs were done 48 hours after the procedure. And at that time, the Barrigel had disappeared within the rectal wall. And in fact, Barrigel that had been correctly placed into the perirectal fat remained. Given that the half-life of hyaluronidase is minutes, if not, it is literally sort of minutes, we were able to actually inject more Barrigel into the second patient for spacing about 2 weeks later. So for the first patient, we wanted to take it easy. We didn't want to take any risk. We dissolved the Barrigel and then commenced the radiotherapy without any issues about 4 weeks later. With the second patient, we actually injected more Barrigel, this time into the perirectal space, and then the patient was able to commence radiotherapy a couple of weeks later. Now, another question, number 2, from a treatment planning perspective, how important is it to have consistent apical coverage, and how do the two types of spaces achieve this? Well, the apex of the prostate is closest to the rectum itself. The base usually has some natural spacing. It depends on your body mass index. Usually I see 2 millimeters at the base for a skinny patient, but it can actually increase to about 5 millimeters for someone who is, let's say, slightly more obese. And this is usually the area where we achieve the best spacing. So particularly for hydrogel, we get, when I was using hydrogel on a consistent basis, we were achieving maximum spacing at the base. And at the apex, and this has been reported and published, we were achieving an average of 5 millimeters for hydrogel at the apex, which is defined as 5 millimeters superior to the apex of the prostate on an MRI scan. And with Barrigel, we've been able to achieve an average of 9 millimeters on the MRI scan. And why is this important? When you look at the planning target volume of the PTV margins that we place for our prostate cancer patients, it's usually 5 millimeters. So when we put a 5 millimeter margin with a spacing of, let's say, an average of 5 millimeters, the PTV margin still may potentially intersect with the rectum itself. Whereas when you achieve an apical margin of 9 millimeters, it's the PTV is nowhere near the rectum itself. So because of that, we achieve the best dosimetric endpoints for our patients. I'm waiting. There's a third question. Some space is better than no space. We can plan around an asymmetrical implant. What are your reactions to this statement? Well, it's partially true when they say that some space is better than no space. But then again, if you have the opportunity to actually achieve symmetrical spacing for all your patients, why wouldn't you choose that? With Nasher, with Barrigel, you have the ability to perform controlled spacing, and you can actually touch up on the go. So instead of allowing the device itself to control your spacing, with Barrigel, you actually control the spacing within the patient. So if there's an area that's under-spaced, you can take your time and actually fill up the gaps. So usually it's at the apex. You can deliver proper apical spacing, and in that scenario, then achieve achieve a insertion that moves the bowel well away from the prostate itself, well away from the PTV margin, so that you can lower the doses or high doses to the rectum itself. And as you can see, for the Barrigel pivotal study, we were able to reduce the rectal volume receiving 90% of the prescription dose by 85%. So we did that quite easily with a spacer that delivers symmetrical spacing. The fourth question is, do you see an advantage to using Barrigel for patients with larger glands? Yep, definitely. With the Barrigel pivotal study, with the Hydrogel pivotal study, we've been limited to prostates that were under 80 cc's in size. I don't know what it is, but in Australia, we do deal with larger prostates. We've dealt with prostates 100, 120, 150 cc's in size. And in that scenario, we are not limited by the amount of spacer material that's available. With Hydrogel, you're limited to 10 cc's. With Barrigel, you can use as many syringes as is required. So for larger glands, I've actually used anywhere between 9, if not 12 cc's of Nasher or Barrigel, and have been able to achieve, again, symmetrical spacing for these patients, not only from the base to the apex of the prostate, but also from right to left. And some people I know may be concerned about the prospects of inserting more than 10 cc's of spacing material. But with Barrigel, given that it's viscoelastic, there's actually no issues with inserting more product if required. Patients actually don't complain of some of the tenesmus symptoms as I had previously experienced with Hydrogel. They actually tolerate it really, really well. That's the last of the questions. I want to thank everyone for attending today's webinar, and I hope you have a great afternoon.